Your arteries, a system of tubes that transport blood around your body. Over time, the buildup of fatty material can damage and clog arteries, restricting the blood flow. This is known as atherosclerosis and can lead to heart attacks and strokes. There are several causes, including high cholesterol, which can clog up your arteries over time, high blood pressure, which can damage areas in your artery walls, making it easier for fatty material to build up over time, and smoking, where chemicals in tobacco smoke can also damage arteries, leading to this fatty material buildup. If a fatty deposit breaks down or ruptures, a blood clot can form around it. This can block your artery. If this artery supplies blood to your heart muscle, it can cause a heart attack. If this artery supplies blood to your brain, it can cause a stroke. There isn't a cure for atherosclerosis, but thanks to British Heart Foundation research funded by your generous donations, we are understanding more about how to treat it. The good news is that you can do something to slow down its progress, and the earlier you start, the better.
Hi, I'm Andrew Jordan, one of the rheumatologists at BJC Health. In today's video, I want to address one of the biggest myths about methotrexate, in that it is a chemotherapy drug. Methotrexate is actually used for rheumatoid arthritis and psoriatic arthritis, and it is used for chemotherapy. The main difference is the dose. In rheumatology, we use it as a tablet that you take once a week at a dose of about 20 milligrams on average. In chemotherapy, it is used as an infusion into the vein and usually given in very high doses, up to 3,000 milligrams or more. The dose difference is about 100 times. So as you can see, I liken it to whether you have one drink of beer or 100 beers. The side effect profile is going to be very different. A lot of the things you may read up online may be actually incorrect, as it's referring to this huge dose that's used for chemotherapy. At the doses we use, the actual side effect profile is nothing compared to the chemotherapy dose, and it is completely inappropriate to consider it a chemotherapy drug when it's used at the doses we use in rheumatology. I hope this answers the myth about methotrexate and chemotherapy.
Methotrexate is a very toxic drug. Has a huge black box warning at the beginning of the package insert that warns us about toxicities to the lungs, intestines, skin, soft tissues, bones, and especially the liver. These adverse effects are a big concern when using methotrexate to treat psoriasis and rheumatoid arthritis. That's because the patient is being exposed to the drug for a much longer time than those patients who are being treated with methotrexate for cancers. We also do not rescue patients who are receiving methotrexate for chronic diseases the way we do for cancers. So we need to monitor these patients very closely. The prescribing information says that we need to check AST and ALT in the blood, along with liver function tests, at least every month or two. While a rise in transaminases doesn't necessarily mean that we automatically have to stop methotrexate, seeing a rise in transaminases does mean that we have to monitor more closely and be ready to stop the drug if things suddenly get worse. In addition to causing acute toxicity to the liver, methotrexate also causes chronic fibrotic changes to the liver. Unfortunately, getting blood tests to watch for liver damage won't always warn us that the fibrotic changes are occurring. Life-threatening fibrotic liver changes can occur even if the liver tests remain normal. So, we need to find another way to see if liver fibrosis is occurring. We need to take a look at a piece of liver. When methotrexate is used long-term, for example, when it's used for psoriasis, it's recommended that the patient have a liver biopsy to monitor for long-term fibrotic damage. When they have this done is determined by how much total methotrexate they've received. It's usually recommended that the biopsy be done before starting methotrexate and after every cumulative gram to gram and a half. For example, let's suppose that someone's getting 25 milligrams per week of methotrexate for psoriasis. That's 100 milligrams a month. So after about 15 months of methotrexate, that person would have received 1,500 milligrams. At that point, another liver biopsy is performed. Then after every gram to a gram and a half of methotrexate, they get another liver biopsy to check for fibrotic changes. Most often that would average out to be about once a year.